Dear friends, it's a pleasure for me to moderate this new webinar of the ENS skill-based section. This webinar is dedicated to the endonasal approach, and we change a little the way we organize the webinar. We will start with the basics and then move to more and more complex surgical procedure. I will share with you my screen. Tomorrow, we will have the chance first to listen to Stefan Lieber, who will discuss with us some very interesting anatomical aspects. And you will see over the coming webinars in the coming months, Stefan coming again to show very impressive anatomical lectures. Then we will listen to the talk of Luigi Cavanaugh on how we do a standard pituitary surgery. Then Sebastian Fröhlich will explain the knee trend for extended endonasal approach. Mahmoud Wesserer will discuss the anatomical relationship in cellar and paracellar regions, how variation can affect the surgical plan. Then Diego Mazzatenta will discuss the role of endoscopic endonasal transtuberculum approach to treat lesions located on supracellular region. And then Henry Schroeder will discuss the skill-based reconstruction after an endoscopic transnasal approach. I'm sure this webinar will still be very attractive. And I give the floor first to Stefan Lieber, working in Paris, in Lariboisière Hospital. Please, Stefan, up to you. Happy that you join our community.
Is it working now, the microphone?
I have to stop to share my screen, and I do it now. Please, Stefan.
All right. I hope it works. The audio as well?
The audio, yes, but I don't see your screen.
Yeah, just a moment. Screen sharing, okay. Just a moment, sorry about this.
Hi.
Oh,
hello, Henri.
How do you like the Greifswald skyline?
We are online and waiting. Stefan, who is just connecting this presentation, but has some technical issue. No problem. We can wait a little. Otherwise, Stefan, if you have some problem, we can move to the next talk. But of course,
it should be.
It is better if we start by the anatomical vision that we.
Yeah, but isn't. I hope it works now.
Yes. Okay, it works. Maybe you have just to move to the full screen mode.
Yeah. All right. So, does it work with the screen? Yes. Perfect. All right. Yeah, thanks very much for having me. So this would be a review of some of the anatomy. Obviously, I cannot cover the entire endonasal ventrolateral ventral anatomy of the skull base. So I just to organize and conceptualize this, the ventral skull base is best organized in the sagittal and the coronal plane. And just briefly to touch on these regions, I prepared just some screenshots for some of the aspects I will not be covering, which is the transcribiform approach, just some of the anatomy, disconnecting the ethmoidal arteries and nerves, connecting with a frontal draft procedure, and then essentially turning this into a craniotomy, extending into the anterior base. I will not be covering this in this talk. This is one of the interior planes in the sagittal plane. This transplantal transtuberculum approach is essentially the anterior or superior extension of the transsphenoidal standard approach to the pituitary. This I will be covering a bit later on. This is the approach to tuberculum meningiomas or craniopharyngiomas, supracellular extension We'll be coming back to this a bit later. This is just to give a modular overview of the topics I will be covering. Then essentially the central axis via the sphenoid sinus to the pituitary. This is known to everyone, transsphenoidal, just a sphenoidal approach via the sinus. Also possible with the pituitary transposition, and then essentially inferior connecting the transclavial approaches in the midline, which can be divided as the transcranial approaches into a superior, middle, and inferior third of the clivus. The superior aspect deals mainly with the third nerve, the oculomotor nerve, the second middle segment extending from the floor of the pituitary or the floor of the sala to the level of the foramen lacerum or the pharyngobasilar fascia, deals with the ascending 6 Dussen's nerve, and then essentially the inferior third with the hypoglossal nerve, some of the mixed nerves laterally. We'll come back to this later. And then essentially the access to C1, tip of C2, inferior tip of the odontoid. Also, this will not be covered in detail. Just give you an overview of the floor of the nasal cavity, a eustachian tube, torus varius, the rectus capitis longus, attachment pharyngeal tubercle here, the muscle layer overlying the inferior clivus, and then drilling out the anterior-inferior aspect of the foramen magnum, tip of the odontoid process, and the rim of C2. So these are the modules in the sagittal plane, and I will be dealing with the transplanum, transtuberculum, the supracell extension, and then sala approach and transclavian approaches in the midline. And just to conceptualize also the coronal plane, which is much more complex, and the anatomy far too complex to discuss in 15 minutes. Just to show some aspects of this coronal plane, there's an interior, a mid, and a posterior aspect to this. The interior aspect is mostly the access to the orbital apex. All of the surgery is essentially surgery around the vertebra of the carotid artery. We'll be coming back to this, but essentially these are all the segments of the carotid artery. There's the cervical C1 segment, the petrous segment. It's extending from the carotid foramen just to the foramen lacerum, which is defined as this fibrous part for the lingual process laterally to the end of the fibrous aspect on the medial side. Then the cavernous portion with the ascending limb, posterior genu, anterior genu, proximal ring is the superior margin of the C5 cavernous carotid. Then there's a very short extra cavernous and extradural clanoidal segment, and then eventually behind the distal dural ring comes the intradural C6 and C7 carotid. Just briefly, some of the modules that can be approached by the endonasal approach in the coronal plane. This is orbital apex and intraorbital pathology. Depends on the reach of this. Superiorly, with adequate exposure, can reach up to the 12 o'clock position. I'm just briefly covering this module. The pterygopalatine fossa is a key step in the organization of the middle aspect of the coronal plane, because it essentially needs to be unlocked for the access to both the pterygopalatine fossa, essentially, then the infratemporal fossa, access to the middle fossa and the lateral recess of the sphenoid. This can be done with in various ways of disconnecting the Vidian nerve, which is the landmark towards the lacerum segment of the carotid. That can be done as a transposition or transection, superior, inferior Vidian approaches. The key landmark in the organization of the coronal plane houses the terminal segments of the maxillary artery, obviously the ganglion, maxillary nerve, infraorbital nerve, greater descending palatine nerve. Then this is the lateral extension in the medial coronal plane, the infratemporal fossa, which again is a complex structure which is reached by a combined pterygoid and transmaxillary approach. This is mandibular fossa here with the coronoid process, and temporal nerve, eustachian tube posteriorly. That's the posterior aspect of the parapharyngeal space. and maxillary artery in the branches of V3. This is, as I said, the lateral extension behind video nerve, which is the lateral recess towards the floor of the middle fossa and anterolateral and anteromedial triangles. This will not be covered in detail, but I will be showing later on some of the Cavanaugh sinus and the more distal part of the medial cranial fossa. Then there is the parapharyngeal space with the eustachian tube, which is resected in this picture. Complex anatomy, which connects anterolaterally with the infratemporal fossa and posteriorly with the lacerum foramen, jugular foramen, petrous ICA superiorly. Just some examples. This is V1, V2, V3, anterolateral, anteromedial triangle. The eustachian tube is dissected. This is C1, petrous carotid up here, and drilled jugular towards with the occipital condyle towards jugular foramen and upperglossal canal. This is just behind the foramen lacerum, which is the posterior structure in the coronal plane, which needs to be controlled and dissected in order to access these lateral structures. So this is a mobilized or skeletonized petrous ICA, the level of the lacerum here and video nerve here. Petrous apex has been drilled, and this is the connection with ovoglossal canal, and then the posterior aspect of the jugular foramen. This is just an overview, and of these modules, I will just be covering a bit of the transpterygoid approach, a bit of the midline structures of the endoscopic perspective of the Cavanaugh sinus, and if we have some time left, maybe a bit of pterygopalatine fossa and the foramen lacerum, because these are the key structures that need to be controlled and mobilized in order to access the coronal plane. For the younger trainees, this is now a stepwise instruction or anatomic review of the sagittal plane. Just briefly understanding of the nose, we have an inferior, middle, and superior turbinate. This is an accessory ostium to the maxillary sinus. This is the sphenoid sinus up here. This is a sagittal perspective. And if this is dissected laterally, it exposes the structures on which the turbinates hinge. This is the attachment, the conchal crest of the inferior turbinate. Then you have the bulla ethmoidalis, the uncinate process, and the anterior and posterior ethmoidal system. Here, the sphenoid sinus, and the basal lamella of the middle turbinate essentially divides all this into an anterior and posterior ethmoidal system. This is now exploration of the nose via the left nostril. So we're looking at the wall of the maxillary sinus here, inferior turbinate, choana, septum, and middle turbinate. This is the axilla of the middle turbinate in the view versus superior. This is the sphenoidal ostium, which is sitting here on the sphenoidal recess of this diamond-shaped aspect of the rostrum. This again is the nasal septum, and if we transect the nasal septum, this obviously is a symmetric structure. You can see the choana, Rosenmüller fossa tuberous tubarius in the back, inferior turbinate, middle turbinate, superior turbinate, the diamond-shaped rostrum with the ethmoidal recess. This is medialization of the middle turbinate, which is here, which exposes the uncinate process and the bulla ethmoidalis. This is essentially the step which you need to do for exposure of the ethmoidal system. And laterally here, the ostium of the maxillary sinus and partial uncinectomy and ethmoidectomy. This now is the exposure for a more, not a standard pituitary exposure, but middle turbinectomy on the left side, on the left nostril, the right side of this specimen for a more extensive approach. And just to show some of the vasculature of the nasal cavity, this is the posterior, the pedicle for the middle turbinate. That's an end branch of the sphenopalatine, the imax branch, which supplies the turbinate. And in the back, you can see it's usually a pedicle for a potential nasoseptal flap, which has been harvested here of the septum and stored in the oropharynx, which is pedicled Again, on end branches, the nasal septal arteries, which emerge from the sphenopalatine foramen, end branches from the imax and the pterygopalatine fossa. I wanted to show this picture also because it shows nicely the connection between the thin bony septum and the diamond-shaped rostrum. And this is depending on the strategy you use, one of the landmark for the mucosal incision, and disconnection if you do a posterior mobilization of the septum or a septectomy or a binostril access in the posterior septectomy window. This is the place where I can disconnect the nasal septum, which connects here with the nasal crest of the palatine bone, which is the vomer, which has been drilled here. Superior connects with the perpendicular plate of the ethmoid, which connects here in this reliable midline structure of the rostrum. And then hidden here, usually hidden under the superior ethmoid, superior turbinate, equal here, windowed on the other side, sits the sphenoidal ostium. This again is a stepwise exposure with the ostia here, peeling of the mucosa on the left side, stepwise exposure of this anatomy. You can already appreciate some of the key landmarks, the genu of the carotid artery here and the orbital apex and the optic nerve. This is planum sphenoidale and the rostrum in the midline. There's, as you know, there's various stages of sphenoidal pneumatization. Depending on this, there is different ways of recognizing these stable landmarks. This is a very ill pneumatized specimen. This is a very large, extensively pneumatized specimen where you can see the pneumatized optic strut. This structure, which sits between the underneath the optic nerve and the genu of the carotid. Again, you have a lot of septations, which are usually not midline and connect somehow towards the carotid. These are not reliable midline structures. And in this specimen, you have a very ill-pneumatized clival recess, but nonetheless, you can appreciate the genu of the carotid and the optic nerve above. As I said, this is the keel of the sphenoid, which is in drilling and exposure of the sphenoid sinus is a reliable landmark, which is not true for the intersphenoidal paramedian septations within the sinus. This is now stepwise exposure of the dura, the periosteal dura of the overlying the pituitary, and that exposes some of the key bony correlates that are relevant for pericellular approaches and sphenoidal surgery. Obviously, we have the genu of the carotid. We'll come back to the segments of the carotid later. This is the optic nerve, falciform ligament. This is planum sphenoidale and limbus sphenoidale. This is the supracellular segment of the dura. This is the intercoronary or intercavernous sinus, and this is the approach to the cavernous sinus and the interdural venous connections on this side. There is some landmarks. As we've seen, this is a partially pneumatized optic strut, which correlates in endoscopy with a lateral optical carotid recess, which is this triangle between the optic and the genu of the carotid. There's another medial optical carotid recess, which is the equivalent of the distal dural ring, and the limbus up here, which is not equivalent with the middle clinoid process, which sits anterior and is the landmark for the proximal dural ring. We saw this later when we discuss some of the anatomy of the pericellular carotid. Just some of the landmarks from the transcranial perspective. Obviously, we have an optic canal. We have a planum sphenoidale, limbus sphenoidale. The lateral extension of the optic strut is the lateral tubercular crest, with the prechiasmatic sulcus in between. Then we have the pituitary, dorsum cellae, anterior clinoid. These are the key structures. This is the fold on just behind the limbus sphenoidale is the fold for the also attachment of the arachnoid relevant in supracellular approaches. There's some bony variations. I had the impression there was another talk about anatomic variation or detail later in this webinar. Just briefly, because this is relevant for the exposure of the carotid and the lateral extension removal of the middle clinoid. There is different ways or different stages of connection between the anterior and the middle clinoid. This is the maximal connection with the carotoclinoidal foramen when there is fusion between the middle clinoid and the anterior clinoid. This is the opposite when there is virtually no middle clinoid process. And this is the stage in between where you have the middle clinoid connecting with the overlying bone, but not forming carotoclinoidal foramen. This is obviously relevant once you want to expose the overlying bone. Just a couple of pictures for the supracellular axis. This is a mix of obviously a transcranial perspective and the endoscopic perspective. We have the optic nerve. There's a cysternal segment. Then there's a segment which is running under the falciform ligament, which correlates with the segment over here. Then there's the canalicular segment, which is right in the optic canal, and then obviously the intraorbital segment, which is towards the orbital apex anteromedially. Just briefly, supracellular exposure. This is preservation of the arachnoid, which protects the intrachiasmatic vasculature, which is consists usually of 3 stable branches of the superior hypophyseal artery. There's a infundibular branch. There's a recurrent branch which runs with the chiasma, and then there is a branch with the infundibulum and the anterior pituitary. These are the vessels at risk in surgery just underneath the chiasma, which are protected in this stage, for example, for medial tubercular meningioma, which is externally located between the arachnoid and the dura. This would be an approach infrachiasmatic and suprachiasmatic, for example, for craniopharyngioma, so supracellular extension of adenomas. We have the stalk, we have the chiasma, we have the caecum communicating segment of the carotid branches of the superior hypophyseal, as I just said, connecting and supplying initially the chiasma and the acom complex just overlying this. This is stepwise exposure of the pituitary and the dural relationships in between.
Nickel. Putain, pas sûr que je vais pouvoir le faire parce que je suis à la bourre. J'ai une réunion à... Quelle heure est-il? J'ai une réunion à 18h.
Some of the supracellular vasculature of the superior hypophyseal and the pituitary stalk. And this is the anatomy of the distal and the endoscopic anatomy of the distal and proximal dural ring. This is the aspect of the middle clinoid. And here you can see very clearly that this is a difference between the attachment of the middle clinoid process, which is the landmark for the proximal dural ring, and the medial optical carotid recess, which is the medial aspect of the distal dural ring, which is not the same, and laterally, obviously, the lateral optical carotid recess. This is the aspect of the medial wall of the Cavanaugh sinus. I will not start a discussion about the consistency of this plane. This is partially capsule, partially fibrous tissue, but it's the often incomplete wall towards the pituitary, between Cavanaugh sinus and pituitary. This is the clanoidal space, which is correlates with the short clanoidal segment of the ICA, which is an extra cavernous extradural segment, and again the attachment of the middle clinoid. This is the medial wall of the Cavanaugh sinus from the inside, and again vasculature of the chiasma and pituitary stalk. Just briefly touching on this is essentially the sagittal plane on the 3 segments of the transclavicular approach. As I said, there is a superior third which correlates with the floor of the pituitary fossa, interpeduncular fossa, third nerve, PCA and SCA arteries are accommodated in this space. The mid-clavicle space usually connects from the floor of the pituitary to to the mid-clivus, again, floor of the rostrum or level of the foramen lacerum, pharyngobasilar junction, or the pons, which is pontomedullary junction here with the ascending sixth nerve. And inferiorly, you see 12 traveling interiorly towards the condyle, mixed nerve in the back, and pica branches of the vertebral artery in the view inferiorly in the midline. Just a bit of detail for the mid-clivus. As I said, this is the ascending limb of the cavernous ICA. This is the pituitary of the genu here, and the other one here. This is the floor of the sella. This is the drilled clavicle recess, and already exposed the basilar, the dura overlying the basilar plexus. This is the level of the foramen lacerum, and this is the ascending sixth nerve, some pacunic granulations here, inferior epiphyseal branch of the cavernous ICA, and Gruber's ligament, petrosphenoidal ligament, which forms part of the roof of the Rallis canal in the back of the clivus. This is the cisternal segment of 6 running here in the Rallis canal. This is petrous apex and reflected or retracted ICA. And this is the course, the interdural course of 6, which enters the cavernous sinus just here behind the carotid. This is mid-clivus now. This is the floor of the rostrum. Again, vomer has been removed. This is inferior turbinate. Rosenmiller fossa torus tubarius, the back of the nasopharynx. This is the first muscle layer, which is the longus capitis rectus. And if this is taken down stepwise, this is again pharyngeal tubercle. The attachments of these 2 muscular layers exposes the inferior clivus, anterior aspect of the foramen magnum. And then we would have the connection with the odontoid process here. The interdural collets, we have this already as vertebral artery, the pica branch here of the inferior basilar, ascending 6 mixed nerves in the back. And this is the region towards the condyle. This is in the second view here is towards the hypoglossal canal with 12th nerve entering into it. Just finishing with some of the cavernous sinus. This is a bit more lateral towards the pterygoid, transpterygoid exposure of towards the medial fossa floor. There's various ways of organizing from the endonasal perspective of organizing the cavernous sinus. This is one way of doing it. It was a paper published by Juan Fernandez Miranda in Pittsburgh, where we based this on the morphology of the ICA. This is essentially just for depiction of this. This is a mid-sagittal section of a left side. This is the ascending limb, posterior genu, anterior genu, and then supracellular intradural extension of the ICA. And the ICA has been cut out here to expose all the structures of a left cavernous sinus, which is essentially the 6th, ascending, as we said here, under Gruber's ligament into the Rallis canal. We have 5 from the back. We have 4 entering the tent, and 3 via the oculomotor triangle into the roof of the cavernous sinus. This is the exposure you would have in endoscopy. Some of the nerves are hidden behind the anterior genu of the terminal ICA carotid. And this is the ascending limb, posterior genu, anterior genu. And based on this morphology, there's 4 compartments which can be described. There's the superior compartment, which is essentially the roof of the cavernous sinus. As in transcranial surgery, the roof is formed by the oculomotor triangle, and the posterolateral, posteromedial extension of the margin is the interclanoidal ligament, which can also be seen here between the anterior and the posterior clinoid. This is dorsum celli here. The horizontal aspect is depressed just to expose the 3rd nerve in the roof of the cavernous sinus. And this is the view, obviously not in the cavernous sinus, but into the posterior cisternal space to see the entry of 3 traveling here between SCA, PCA, and 4, which enters the foramen over the roof of the cavernous sinus also. This again is abducens nerve in the posterior compartment, which is just behind the ascending limb of the cavernous ICA. This again is Gruber's ligament. This is the nerve. This is some of the branches, claudal branches, inferior epiphyseal branches of the meningophyseal trunk. The inferior compartment does not really have any real structures to it, except for maybe the sympathetic plexus that runs here on the cavernous ICA, and some of the V1 branches that travel towards the lateral segment. But usually this is just behind the ascending limb of the ICA. And finally, the lateral compartment, which is hidden behind the anterior genu. In order to visualize this, the anterior clanoidal, the clanoidal rings and dual rings need to be cut, and then the genu needs to be medialized, which exposes the inferolateral trunk, 3 ascending nerves towards the superior orbital fissure, which is essentially between the optic stratia, maxillary stratia. So this is the space of the superior inferior superior orbital fissure, which is just a free space between cavernous sinus, lateral cellular compartment, superior orbital fissure, and orbital apex. Just a few details about the microvasculature.
Stefan, we will have to conclude because the
yeah, this is perfect. This is 3 slides. I make this perfect. I make this short. Just some of the microvasculature, as I said, inferior epiphyseal artery and lateral inferolateral trunk encountered in the cavernous sinus. Meconal perforatus, supracellular perforatus, and superior epiphyseal artery connecting or supplying chiasma, optic nerve, and fundibulum. This is some anatomy of the foramen laterum. I will skip this for now. Again, one of the regions that needs to be controlled for access to in the coronal plane. This was a brief review. I hope it was helpful for the sagittal plane and the understanding of the nasal stages. Thank you.
Thank you so much, Stefan, for joining us. Your talk was truly outstanding. Your images were wonderful and the explanations very clear. A very nice introduction for our topic. Sébastien has to leave us very quickly after his talk. So please, Sébastien, up to you to discuss with us the new trends in the endoscopic endonasal approach, please.
Thank you very much, Michael, for putting together first those webinars. It's very nice. We had a very nice review of the anatomy from Stefan. So the only thing I wanted to talk about extended endonasal approach is to take the opportunity of this webinar to show some of the things we are trying to do to reduce the aggressiveness of the approach. I think in skull-based surgery in general, whenever we push a new technique forward, we also have to think on how to make it softer for the patient, to reduce the footprint of such approach. Our practice is based on extended endonasal approach quite a lot because we have a big referral for chordoma patients. So I am facing quite often large tumor, clival tumors such as chordoma, or tumor extending into the cavernous sinus such as chondrosarcoma. As you know, for those tumors, extended endonasal approach has really changed the way to treat those patients. Reaching the clivus with a transcranial approach is extremely difficult. It's very far, very deep. But if you come from the nose, it's really straightforward. It's really in front of us. But with extended endonasal approach, the technique have been described to increase the size of the corridor, the volume of space to work, resecting some endonasal anatomy, such as middle turbinate, nasal septum, posterior ethmoid, anterior ethmoid, depending on the extension of the tumor. And whenever you take some normal tissue, whenever you remove the mucosa into the nose from the bone, for example, you create some morbidity like crusting, loss of smell, bad smell. At the level of the craniocervical junction, if you remove a tumor, you remove some posterior pharyngeal muscle and mucosa, you may have some velopharyngeal insufficiency. If you go even more laterally next to the pterygoid muscle and you remove some normal structures, you may have also some mastication difficulties and also hearing issue if you work next to the eustachian tube. We also know that the issue of CSF leakage, especially at the level of the clivus for tumor like chordoma, is not solved. It's much better for pituitary adenoma, obviously, and also for craniopharyngioma and tuberculum cellae meningioma than it used to be at the beginning of endoscopic endonasal. Experienced team have lowered significantly their rate of CSF leak, even if it stay, I think, between 5 and 10%. But at the level of the clivus, it's much higher than this. And all the team who are doing a lot of clival chordoma have similar experience when the dura is open, obviously. For tumor like this, for example, the surgical footprint of the approach, you need to remove a lot of endonasal structure to expose the tumor on both condyle. Well, it has a cost for a patient, as I said. So I think we need to try to reduce the approach morbidity. For this, first, we need to try to be less aggressive, respecting the endonasal anatomy as much as possible, taking advantage of the paranasal cavities, but without creating a big working volume. That's the true meaning of the endoscope, in fact, to take advantage of what nature gave us, to go deep into the sphenoid sinus and not necessarily to create a big working corridor. We also have to improve dural closure. We saw that CSF leak is still an issue, and maybe to select better the indication. So we have tried to reduce the aggressiveness of the approach by using this technique that we have published. I use it for 10, 15 years now. I hold the suction with the endoscope on the same hand, and I hold an instrument with my right hand. Doing so, I'm not using a holder. I have everything in my own hands. And the smaller is the cavity, the easiest it is, because in fact, the holder is the endonasal anatomy. The corridor is very small, so the endoscope cannot move around. My section cannot move around. It can only go straight. And again, the endonasal anatomy is my holder. This is how I work with the endoscope on the suction on my left hand. You see that the endoscope is just between my thumb and finger. I am just supporting it. I am not holding it. And the rest of the fingers are manipulating this rotative malleable suction. And it's absolutely key to have a rotative malleable suction. You see that I can bend the tip of the suction 90 degrees here, which means that when I rotate here with my two fingers, I can browse a very wide, a very large volume deep into the nose. So again, the less is removed into the nose, the smallest is the corridor, the easiest it is for me. If I do a classic extended with removal of the septum, removal of the ethmoid, posterior ethmoid, anterior ethmoid on both sides, then I have a big cavity. I cannot just support the endoscope. I have to grab it, to hold it, to put strength into it. And then I lose the ability to manipulate my section with my remaining fingers. This is an example of how I use it. You see that my fingers are holding the tube, rotating the tube, rotating the suction. Most often I am just supporting the tube of the aspiration, not more. again, there is no space for those instruments to move anyway. The advantage is that I can really have my endoscope very close from the tip of my instruments without sword conflict. And one of the main issues with endoscopic endonasal technique is when you want to be very close with the tip of your endoscope from what you are actually doing with your instruments, then you increase the sword conflict between the endoscope and the instruments. If you hold everything, then you don't have this issue of sword conflict. You also need angle endoscope. I never work with a 0-degree endoscope. I always work minimum with 30-degree endoscope, sometimes 45, sometimes 70. Here it's a 70. Looking at the petrous apex, where I have removed a chondrosarcoma, and you see that I am also using bended ronger. It's almost bended 90 degrees to really go deep into the petrous apex without a need for transposition of the carotid artery or transperigoid approach in this case. You can also bend the suction more than 90 degrees to work behind the paraclival segment of the ICA and above the C2 segment. We have also moved to a new step, trying to be even less aggressive. And we published recently this manuscript, in which we describe a technique where we keep the mucosa of the nostril, of the rostrum, sorry. We incise the mucosa of the rostrum, and we consider this mucosa of the rostrum as, in fact, the endonasal skin. It's like when you do a transcranial approach, you open the skin, you do a frontotemporal incision, you do whatever you need to do into the head, and at the end, you close the muscle and you close the skin. And the skin is the best barrier to avoid CSF leakage. We do exactly the same into the nose. The rostral mucosa is our skin. We make an incision. We drill the rostrum of the sphenoid, which gives us a lot of space to work. We get into the sphenoid sinus. We remove the mucosa of the sphenoid sinus. We remove the tumor on the clivus, on the sella, Cavanaugh sinus eventually. We use this working space given by the sphenoid sinus and the tumor using angle instruments. And at the end, we put a big piece of fat into the tumor cavity and sphenoid sinus. So we cranialize the sphenoid sinus and we suture the mucosa of the rostrum. It can be stitched because the mucosa of the rostrum is very thick compared to, for example, the mucosa of the roof of the nasal cavity. So this is a cartoon to show you what we do. We make this incision here a little bit in front of the rostrum. We peel the mucosa on one side and on the other side. We drill all this volume of bone of the rostrum, remove the mucosa of the sphenoid sinus, remove the tumor, put some fat, and at the end, we do a stitching. I show you a few cases. I have several cases. I will not show all of them. This was a patient with a chordoma, with a little intradural extension, not so much. And you see that this chordoma, in fact, is a little bit below the sphenoid sinus. It's not a big tumor. It was some of our first cases. This patient had a biopsy before, and he had a nasal septum perforation that you can see here. So there was no nasoseptal flap available in this patient. So this is where I got the idea of just making an incision of the rostral mucosa and stitching it at the end. So here is a video of it. This is the scar. I will do an incision here just at the level of the rostrum, a little bit low because the tumor was below the sphenoid sinus. I peel here the mucosa from the rostrum. It's a one nostril approach. I didn't took the middle turbinate away. I just push it on the side. Again, it's a chopsticks technique. I am holding the suction with my endoscope. I am peeling here again the mucosa from the rostrum. I am taking advantage of this volume of bone of the rostrum as much as possible. I am running below the sphenoid sinus. The mucosa of the sphenoid sinus, in fact, was not open. It was just pushed upward. We went below the sphenoid sinus. Navigation is useful at the beginning to identify Vidian canal, the important structure here, because there was not so much pneumatization. I was not into the sphenoid sinus, but only into the rostrum. Navigation helped me. I went down below the tumor limit at the level of the clivus, lower clivus. In chordoma, you need to drill a lot of bone because bone is most often infiltrated. And progressively, I remove the tumor. The advantage is that chordoma are soft, so it's not so difficult to remove once you are on the tumor. What's important is to remove and to drill all the bones that you feel is infiltrated. Then, this was a little hole through which the tumor was going intradurally. I use angle scope, angle instruments, angle malleable suction to really go into the corners. Here it's down at the level of the lower clivus. At the end, I put a piece of fat into the hole. I put some fat into the cavities that we have made, and we are going to stitch this mucosa. This is one technique I use at the beginning, but I have changed it now to make it much easier. It's a little bit challenging to stitch, but not so difficult. It takes a little bit of time and patience, but with a little bit of training and experience, it's much easier to stitch the mucosa of the rostrum, which is about 4 or 5 centimeters deep, than stitching, for example, the dura mater of the clivus, which is much deeper, 3 centimeters deeper, and much more challenging to stitch because it's really a coronal plane. So here I do running stitch, and at the end I block the node with a little titanium clip. Until now, I had no infection. I probably did around between 10 and 15 cases like those. I had no infection of the fat until now. So this is a cartoon showing the technique: removal of the tumor, putting fat, and stitching. This is a post-operative MRI. What's nice is to look at the endonasal anatomy that is exactly the same than preoperatively. This was another case, bigger case, big tumor, but the biggest is the tumor, the better it is for me because the tumor gives me some space to work. So here, same technique. We do this incision on the rostrum. You see that the mucosa is pushed forward by the tumor. Exactly the same. We drill the rostrum of the sphenoid. We get into the sphenoid sinus in this case to remove the mucosa of the sphenoid sinus. You need to remove all the mucosa because otherwise you will have a mucocele. Again, it's a cranialization of the sphenoid sinus, so extremely important to take it all out. There was a tiny little opening of the dura. This is Petrus apex with Petrus ICA. Malleable bended instruments like before. Resection is complete macroscopically here. And at the end, I have this opening. I full file the cavity with fat and I stitch the same way than before the mucosa. I think it's very nice also against CSF leak because it's probably the strongest barrier for CSF leakage. When you put a nasoseptal flap, the nasoseptal flap is not supposed to be watertight. It's just something to cover and to bring vessels on what you put to close, but it's not made to close the nasoseptal flap. So I think here, what I do with the mucosa is really made to close. Look at the endonasal anatomy, it looks normal. This is another case, 59 years old, 6 nerve palsy, similar tumor of the clivus. I skipped the video because I am a bit late, but exactly the same technique, resection of the tumor. I go fast at the end to show the stitching. Again, a little bit painful at the beginning, but much easier than stitching the dura mater. This is post-operative MRI. Endonasal anatomy is very normal. Same case here, but with a larger intradural extension. We did exactly the same technique. One nostril pushing the turbinate on one side. We never work both nostrils for those cases. Just one incision here. We take the tumor progressively out. You need really to have angle endoscope to go and to look around corners, but this is the true meaning of the endoscope, to go around and to look around the corner. So you need specific instruments. And at the end, fat into the cavity and stitching same than before. The patient is very satisfied. The morbidity of the approach is not zero, but it's extremely limited. I think I am almost done. This is another case I did recently. You see between post and preoperative and post-operative MRI, the only thing changed is the signal of the tumor, which is now a signal of fat. But the endonasal anatomy is exactly the same. Michael, I think I will stop here.
Okay.
I will stop here.
Okay. Thank you so much, Sébastien.
You're very welcome.
Impressive to see over the months and the years how your techniques are evolving to reduce the morbidity. But you are also very skilled, and at the end, it will be very interesting that you perform a functional MRI, because holding two instruments in the same hands, something is special,
No,
different.
alors, if I make something, in fact, it's absolutely not difficult. And I don't say that because I do it. I really think it's not. It's a technique where you should not use strength. You just support instrument and suction. This is my endoscope, and with my suction, the only movement I do is this. But whenever you put strength, then it starts to be complicated. If you grab the endoscope and you put strength, then you cannot do that. It's quite easy because the anatomy is helping me, and I am just, taking advantage of this small corridor that is holding the instrument for me. It's just a question of concept, but quite rapidly I started this for pituitary, and over the years I have been quite satisfied.
It's impressive. So have a nice travel, Sebastian. I know that you have to leave us. Thank you to be with us.
Yes, thank you very much. I'm sorry I have to leave, but I wish I could be with you guys for the discussion.
Bye-bye.
Bye-bye. Bye-bye. Take care.
Then we move to Lausanne to listen to Mahmoud Messerer, and I'm very interested to listen his talk on how the variations change his surgical plan, especially in cellular and paracellular regions. Please, Mahmoud.
Okay, thank you very much, Michael. Many things have been said. I will talk about anatomical relationships in cellular and paracellular regions, how variation can affect the surgical plan. When we look at the literature, we can find 20% of complication after endoscopic endonasal approach. Fortunately, the majority of these complications are benign, but don't forget, we can also have serious complications like vascular injury. So when you ask yourself if the endoscopy endonasal approach is minimally invasive approach, in my opinion, the answer is clearly no. Now, how to avoid this kind of complication? The key, I think, is to careful analysis the images before the surgery. You have to analyze the nasal fossa, the pneumatization of the sphenoid sinus, the posterior ethmoid cells, the septation inside the sphenoid sinus, the relationship between the tumor and the optic nerves, if there is or no cavernous sinus invasion, and the anatomy of the ACA. First of all, you have to decide from which nostril you have to approach your lesion. If you have an example of septal deviation or middle turbinate hypertrophy, of sure you have to choose the larger corridor. If you are in front of lateration of your lesion, if your lesion is lateraceous, on the left or on the right side. Personally, I prefer to put the endoscope in the contralateral side because the view is better. Generally, I use a uninostril approach, but when I need a binostril approach, I put the endoscope in the contralateral side of the lesion and my tools in the homolateral side. When you deal also with the conchal sinus, don't hesitate, and you need to use navigation. It's very helpful, especially when you drill from the anterior wall of the sphenoid sinus to the sellar floor. Also, when you approach, when you need to approach transpterygoid fossa or infratemporal fossa, it's very important to search if you have a lateral recess, especially when you want to reach the temporal fossa from below. If there is no large lateral recess, personally, I prefer transcranial approach in this kind of situation. I want to share with you some cases. This is a 50-year-old woman. She came for spontaneous CCF rhinorrhea. She had previous surgery for chiari malformation and hydrocephalus. For this rhinorrhea, we did an MRI, and we can see here in the sphenoid sinus the CCF leakage, and in the lateral recess, we can see here the encephalocele. And in the coronal CT scan, we can see clearly the defect. So I did a transnasal approach. Why? Because I have a large lateral recess. This is the intraoperative video. It's very important to open widely your sphenoid sinus, your posterior ethmoid cells, your maxillary sinus, to see and to individualize all your encephalocele. I drill the pterygoid plate, and when I remove completely my encephalocele, I can see easier my defect here. It's very important to see all your defect and your normal dura, and after that, I do my reconstruction with the fascia lata gasket seal technique with the bone preleved from the anterior wall of the sphenoid sinus. And finally, I do a flap from the middle turbinate. This is the flap from my middle turbinate, and it's enough. You can, the patient is well, and there is no CCF leakage after this procedure. It's very important also to analyze your septation inside your sphenoid sinus. Septation inside the sphenoid sinus is like fingerprint. It's unique and it's very helpful. It's like road signs, especially when you deal with the microadenoma and when you need also to localize your ACA. Donc, this is a typical case of Cushing disease. The microadenoma is here, just lateral to the medial septum. You don't need to open widely your sellar floor. You need just to open in front your microadenoma, lateral to this medial septum, until the medial wall of the cavernous sinus. We know the carotid is here, the microadenoma is here, and we can do your selective microadenectomy. Another case, 57-year-old man, he came for headaches and right exophthalmia, and we noted in his previous history a cranial trauma 15 years ago. So we did the MRI, and we see in this MRI a collection inside the posterior and the anterior ethmoid cells, but the pitfall here is to individualize your the trajectory of the optic nerve. We see here the optic nerve, and when we follow this optic nerve, the optic nerve is inside your mucocell. This is the optic nerve. And if you don't worry about this particular anatomy, you can damage easier your optic nerve during your resection. This is a video. This is the content of the mucocele. We have to open widely the sphenoid sinus, and we know the optic nerve is not so far from here. So it's very important to open widely, and this is the optic nerve. The optic nerve is here. Look, you cannot manipulate directly on the optic nerve. We put the instrument superior or inferior because we are aware the optic nerve is here. Without that, we can easily have a big problem with this important structure. Another important question we have to analyze if there is an invasion of the cavernous sinus. It is a typical case. We have a lesion inside the cavernous sinus. This is the normal pituitary gland, ACA here. It was hemangioma. The patient came for left sixth nerve palsy. This is the exam pre-operatively. We did a transsphenoidal approach. We have to open the cellular floor. We protect the normal pituitary gland and is here. And we have to work between the pituitary gland and the carotid artery. We did a piecemeal resection. It's very important to go step by step. This is the anterior part. After that, we go medially through the medial wall of the cavernous sinus here. And the last piece is posterior to the carotid artery. The carotid artery is here. And we can do a gross total resection. This is the post-operative exam. There is no palsy of the cranial nerve. So it's very important to see before your craniotomy all the important anatomical landmark. In the midline, the planum, the tuberculum, the cellar, and laterally the optic nerve, the carotid artery inside the cavernous sinus, the paracreval carotid artery, and the medial and the lateral optical carotid recess. It's very important to see all this anatomical nerve. Without that, you can have a big problem when you do endoscopic endonasal approach. When you decide to do extended approach, you have to do properly your extended approach. It is an example for craniopharyngioma. It's very important to open until the medial optical carotid recess to see the emergency of the optic nerve. Without that, also you can damage this important structure. It's very important to planify your surgery before. Planification is very important in this surgery. And finally, I want to share with you this case. I operated this case last week. It's a classic microadenoma, Cushing disease. As usual, my resident did the approach. When I was in the OR, I asked him, everything is okay? Yes, everything is okay. He told me this is the cellar, this is the lateral optical carotid recess, and the carotid artery. But we can see here, we have a particular anatomy. The cellar is a little bit upper and just behind the posterior ethmoid cells. I asked my resident, did you open the posterior ethmoid cells? He told me no. And immediately I know there is a big mistake. I want to show you. This is not the cellar, but the clivus. He opened more inferior, and fortunately, he stopped just in front of the dura. We can see the basilar plexus, and fortunately, there is no problem with the basilar artery. So it's very important to planify your surgery before, especially when we work in this small corridor. This is the normal cellar here, after opening the ethmoid cell, because you can have a big trouble in this kind of surgery. Thank you very much.
Thank you so much, Mahmoud. You made the gap between the normal anatomy described by Stefan and how this anatomy should be applied to before operating any patient by looking at all the variations that could be put you into trouble during your surgery. Very interesting to make this gap. So now we move to the talk of Diego Mazatenta, who will discuss with us the role of the endoscopic endonasal transtuberculum approach to treat lesions located on supracellular region. Please, Diego, up to you.
Okay, thank you all. Thank you, Michael, and all the colleagues.
Can you stop to share your screen, Mahmoud, maybe?
Yes.
Thank you.
Yes. Okay. Do
Please,
you hear me? Do you see me?
We can listen to you. We have not yet your PowerPoint.
Okay. It's coming. Okay. Do you see?
Not yet in full mode. Yes, it is. Perfect.
Okay. It's work.
Perfect.
Good. First of all, I'm very happy to join the Eans School Bus Board. Thank you for Michael and all estimated colleagues. My name and my name of all Bolognese Skull-Base Group. Thank you for the invitation. We are very proud to work together and improve the excellence of Eans Skull-Base Board. And historically, the transsphenoidal approach has been reserved for intracellular or intrasupracellular subdiaphragmatic, for example, craniopharyngiomas. In the last of the 80s of the 20th centuries, there were the pioneeristic paper wrote, for example, Weiss, to use the microsurgical technique to try to enlarge the transsphenoidal approach to the supradiaphragmatic approach. In fact, at the end of centuries, the 20th centuries, Mason wrote a paper, and the cover of the Journal of Neurosurgery was dedicated to his paper because he described the approach, the supradiaphragmatic approach with the microsurgical technique to remove the pituitary stalk HETH secreting pituitary adenomas. But the extended approach to supradiaphragmatic approach improved and became one of the approach for the treat a lesion located on the supradiaphragmatic space during the endoscopic era. This is the paper wrote 80 years ago from my mentor, Giorgio Frank. We described the best indication for this type of approach to allow an extracapsular technique to remove the pituitary adenomas growing in the supracellular space, managing the dome of the tumor and dissect its need to vascular nervous structures such as A1, A2 complex and chiasm. Obviously, this is the paper wrote from Amin Kassam, and which the structure we need to perform this type of approach. The corridor is a sphenoid and a post-ectoid region, and the anatomical boundaries are the medial optic carotid disease, the optic, the bone of boundaries when around the optic nerve, and this is the region of tuberculum cell and the planus sphenoidalis. As you can see, the extension of standard cellular approach is very easy to achieve. It's enough to opening this bone, sometimes very thin bone, and gain access and work above the plane designed by the diaphragma cell and work in the supracellular space. This is the our semi-sitting position. We use traditionally the RD position, not Cushing a supine position. The head is lightly tilted, and you can see the two main corridors to open the transtuberculum region. Obviously, the wide anterior sphenoidotomy and the lateral displacement out of fracture, without cutting or fracture the middle turbinate, it's enough to gain more space in the cellular type. The colleagues before described the different type, the precellar and the coccal type. In this case, obviously, it's need to create an adequate space work and could be effective to perform the posterior septostomy and also the middle turbinectomy and posterior tumodectomies. These two last steps are not mandatory. The take-home message is a tailored approach. In other words, if you are in front of the cellular type, the sphenoidal sinus sometimes, always, almost always, it's enough to work to approaching the transtuberculum area. This is a case, a craniopharyngioma, asymmetric with different component of the tumor, as you well recognize the chiasm and the complex A1 and A2, and we decided to use the transtuberculum approach to reduce and drainage the kyst after following maybe the radiotherapy. We start, as you can see in this clip, the holder is fixed by the endoscope is fixed by the holder. We don't use the free hands. And we start with two hands techniques as usually for example, for microsurgical technique. As you can see the manage of the kyst of lesion, you can see posteriorly the chiasm and the A1 A2 complex, but the take-home message of this clip is, as you can see, we can manage also the lateral kyst of the tumor, and we stop the tumor removal, just the portion, a little portion, completely fused in the carotid artery M1A1. To work and to remove this type of tumor, it was enough only spheroidotomy. Middle turbinate are preserved, ethmoidal box are preferred. This is the early CT scan post-op of this case. This was the result of tumor removal, and this is the control after 3 years. And this is the follow-up of the patient. It was able to discuss its thesis on the University of Physics in biophysical model and synaptic plasticity. What does it mean? It's important also the quality of life when you perform this type of surgery in craniopharyngiomas. Obviously, in the concal type, for example, in pediatric craniopharyngiomas, there is no space and there is no pneumatization of the sphenoidal sinus. So it's needed to create an adequate space, drilling out the sphenoidal sinus in concal type. As you can see, it's mandatory to use the narrow navigation. With the use the drilling, it's possible to create an adequate and sufficient space in the nasal fossa. When you're in front of the dura madre using the narrow navigation, you can open the sella and the supracellular space, and the tumor removal continues as usual. This is the post-operative MRI. As you can see, it's what's not necessary to remove all the bone, but just to work with two hands technique. The intradural plane, there are other structures more important, the supracellular system and the anterior circular Willis, chiasm, optic nerve stalks, and in case of very large lesion, gyrus rectus and orbitofrontal gyrus. This is a case of a young female, 34 years old, affected by amenorrhea and diabetes insipidus. As you can see, the tumor was located completely in the pituitary stalk. And after multidisciplinary discussion, we decided to perform a surgery. You can see the sella turcica open, the diaphragma cella open, the pituitary gland, the pituitary stalks, where is located the tumor, and the stalk is enlarged by the tumor itself. This is the dura madre of tuberculum cell. You can see very well above the optic chiasm, and with two hands technique, we try to perform a very selective tumor removal, respecting the anatomy of pituitary stalk when it's possible. If it's possible, we try to preserve. In other type of tumor, it's not necessary, it's not sense to try to preserve always the pituitary stalks. In this case, it was possible. You see the two hands technique, the tumor removal, and the final inspection with the preservation of an anatomical preservation of the pituitary stalk, dorsum celle, and optic pathway at its chiasm. This was the MRI post-operatively with the fat for the closure, and this was the issue of anatomopathological spindle cell oncocytomas, variant of pituitary. When use the endoscopic endonasal transtuberculum? Always no. It's not question of fate. In this case, this is a grade 3 with using the CASAM chiasm. We can see the very normal tile of ventricle. This is the position of A1, A2 complex and the chiasm. This is the window using the transtuberculum approach, and you can work using the angle endoscope and the angle instrumentation to try to remove. And this was the results post-operatively. Same position, same lesion, but in this case, there is a very important ventricular dilatation. The A1, A2 complex are located in front of the tuberculum cell region. This was the chiasm, and obviously we choose the transventricular approach, and we achieve the radical gross total removal. The chiasm design a plane, and there is two main different displace possibility created by the tumor. The tumor growing up and displace the optic pathway, and below the optic pathway, the A1, A2 complex are more safe and more safely approaches if you choose the transtuberculum approach. Conversely, the tumor that push inferiorly the chiasm and displace the A1A complex require a very delicate dissection with the dome of the tumor for the vascular structure. As in this case, you can see the optic pathway, the optic thread, and the chiasm. Conversely, the A2 arteries run in the top of the tumor. Same approach, cella turcical region, tuberculum, boundaries of the optic pathway, opening the dura madre. This is the meningiomas of tuberculum cell. You can remove the tumor as you prefer. You can use also the cavitron on the curette, central debulking of the tumor, and when the tumors are removed, you can dissect the dome of the tumor for the neurovascular structure. As you can see, the final exploration, preserve the pituitary stalk preserved. This is the optic nerve on the left side, and this is the technique of occlusion, but this is another argument in the following communication. This is the post-operative results with the pituitary and its stalk preserved. The radical removal was achieved. And in case of you use the transtuberculum approach to remove the tuberculum cell meningiomas, don't forget the main gold aspect of this technique. You can mobilize the optic nerve after the tumor removal. And so this is very important because the mobilization of optic nerve is performed when it's not hooked by the tumor. And so you can manage the optic structure after the decompression, after the tumor removal. There is another type of tumor can be managed in this region is the optic glioma. We published 7 years ago the preliminary reports. It's important to remind that the large part of optic hypothalamic gliomas are hypothalamic gliomas of astrocytoma pilocyticus, grade 1 or 2 in the WHO grade. And we use for gross total, radical, or biopsy in only selected cases. I show you this case. This is a young male, 23 years ago old, affected by a myopia. As you can see, this is the MRI post-op. You can see the optic thread, the chiasm, the pituitary stalk, the pituitary gland, the carotid M1, A1 arteries, It's not easy to manage and decide this is a craniopharyngiomas or glioma. So we decided to use the endoscope. During the tumor removal, now we used a new technique of tractography of optic pathways. This is very useful because if you use that information intraoperatively, as you can see, this is the suction tube navigated, and you can see where is the optic pathway previously studied with the study of tractography by MRI. As you can see, this is the tumor, this is the optic pathway, and you can see the chiasm completely displaced in the right side of the surgical field. When we check and integrate it with the visualization, intraoperative visualization, we can try to perform a gross total or more larger tumor removal. This was the results of post-operatively. The results was a pilocytic astrocytoma grade 1, and this was the post-operative, early post-operatively MRI post-op. Another case for tumor located in the planum tuberculum area. This is an old male, 74 years old, affected by anosmia from several years and recent visual loss. We performed this the MRI and showed the lesion with a hyper-intense material inside, probably a cyst lesion. As you can see very well, the tumor growing above the optic pathway, but the optic pathway is displaced posteriorly. So we decided to use the transtuberculum approach, and also in this case, we use the tractography for the optic pathway, also for during the opening the access, to check all times, real times, where is the displace the optic pathways and opening safely the dura madre. When we check the tumor was completely anteriorly in the our windows, we proceeded with the tumor removal. This is very quickly the tumor removal. As you can see in this fat material inside in the kyst lesion, we start with the tumor removal. We start with the removal of the fat material, and after we dissected the capsule of tumor for the optic pathway and then chiasm. There is a very close relationship between the capsule, the tumor, and the optic pathway. As you can see, we work above the plane designed by the chiasm and the optic nerve. Posteriorly, there is A1, A2 complex. This is the gyrus rectus. We try to dissect the tumor, the capsule, managing the optic pathway. Posteriorly, A1, A2 in the right side. Obviously, this is the dissection of the capsule from the gyrus rectus, and also the manage the frontopolar arteries. When we arrive in front of the A1, A2 complex, it was impossible to dissect, and we stopped the tumor removal. This is the lamina terminalis, and it's not usual to see this region because we work traditionally inferiorly to the optic pathway, and the tumor push up also the lamina terminalis space. And I show you quickly the confirmation during the tumor removal to use also in this case the tractography for the optic pathways, and the close correspondence between the navigation and the MRI pre-op. This was the results, and the diagnosis was intracranial mature teratoma. Another case, this is a young female, 46 years old, affected by, was previously operated 2 times in pediatric area 70 years ago for dermoid. He was affected by a blind from the left eyes. Unfortunately, the tumor progressed and affected visual loss in the only eyes, in the right eyes. We decided to use the transtuberculum approach. This is the chiasm, this is the A1 arteries, and we choose the transtuberculum approach as usual, the enlarge of the bone, double incision of in the cellular plane and the supracellular. We opening the dura madre. We remove the capsule of dermoid as much as possible, remove the material inside the kyst, and we explore the surgical field, and at the end we perform the plastic repair. This is a very recent case. We are only the CT post-operatively. In conclusion, the endoscopic endonasal approach or transtuberculum is a good option. It's not a question of faith, it's only an option, and we can use when the anatomical condition respected the good indication. If better to use the standard transcranial approach, you can use the standard transcranial approach. Our talks would to stimulate a debate, and it's not only for the craniopharyngiomas or meningiomas, but also for the other type of tumor, large and very small, such as a tumor located in pituitary stalk. Thank you for your attention.
Thank you so much, Diego, for your very interesting talk. We started with the anatomy. We discussed the interest of integrating the variation in the surgical procedure. We see very interesting extradural tumor resection. You move one step further and highlights the limits to resect intradural lesions. And now it's naturally that we will discuss the skull-based reconstruction, and it will be done by Henry Schroeder. Please, Henry, I give you the floor.
Yeah, hello. Can you give me the screen, Diego?
Oh, sorry. Are you okay? Sorry. It's okay.
That looks better. Thank you. Dear Michael, thanks again for the invitation to this webinar series. So my task is the endonasal skull-base reconstruction. Of course, before you start with the surgery, we have to keep in mind how do we close a defect. And this is especially important in endoscopic endonasal skull-base surgery because of the risk of CSF leakage. So therefore, we have to look at the imaging before. So we always do a CT scan to have an idea about the anatomy. And then, of course, we do an MRI. And we want to judge, is the lesion, is it extradural or is it intradural? Because from this tumor location, it depends what type of skull-base reconstruction we should plan. So it's of utmost importance before you start with the surgery, you should have an idea how do you want to close a defect. For example, here, if you see this chordoma with clearly intradural growth, you know you have to make a robust reconstruction, otherwise you will have problems with a continuous CSF leakage. So I just want to give you our techniques for skull-base reconstruction. I don't want to review the literature. You can do it by your own. I just want to give you some examples how you can deal with CSF leakage. So when we have no CSF flow during the surgery, usually in pituitary cases, we just place gel foam in. Sometimes we use bone or a resorbable plate made from polydioxanone. If we have a minor CSF flow, usually we put some collagen in, Duragene, for example, and we reconstruct the bony cellular floor with this resorbable plate. If we face a major CSF flow, we usually would use fat, fibrin glue. If it's a big defect, an opening of the third ventricle, I still place lumbar drains. And then, of course, the nasoseptal flap, if it's available. So examples, when do we use bone? For example, this was a lady with a Cushing, typical Cushing disease. When you look at the MRI, you see there is small intracellular adenoma located at the Cavanaugh sinus. You see the diaphragma cell seems to be very thick. And usually in these cases, you don't see any CSF flow. So what I like to do is that I remove the bony cellular floor as one piece, and I take care that the longitudinal axis is longer than the vertical axis. So we open the gland to see the tumor. Usually we try to find a pseudocapsule, but frequently in these small adenomas, it's not possible. Here in the end, we have a kind of pseudocapsule where we can go around. So the tumor is removed and you see there is no CSF leakage. When we look inside, there is gland above the diaphragm or below the diaphragm, and then we place the bone back and we turn it 90 degrees. So it's wedged under the bone here and the bone here. So we have a bony reconstruction. This is not always required. Some people say also, no, we don't need it. This is a lady after surgery. See post-op, the adenoma is removed. The lab is good, and 2 years after surgery, she's a nice girl and got birth to a baby. Another technique which can also be used is also a small adenoma. I use the 1 millimeter kerrison because this takes less bone and you can cut around and then you lift the bony floor. This is of course not possible if you have larger tumors and the cellular bone is very thin. But in the small microadenomas, usually you can preserve the bone. And then after tumor resection, I bring it back and then I turn it 90 degrees and it is wedged under the bone of the margin of the opening. Some people say it's not required. It's okay. CSF leakage is very unlikely because the diaphragm is thick, but I like to reconstruct the bony floor as well. Then we frequently use a resorbable plate. When we remove the tumor, we put some gel foam or Duragene inside the cellular space, and then we place it in the epidural space. And we put it against the bony opening of the cellar, but outside of the dura usually. We published 30 cases and we had quite good results. For example, this was a lady with an non-secreting tumor. See, the tumor is only a little bit elevating the diaphragm. It's on the right side in the cellular space. So we open the dura. And then we try to find a good plane between the tumor and the gland. And you see here we have a very nice pseudocapsule where we can go around. So this is typical the tumor. So this is our gland. And you see this, and there's a nice border between the normal gland and the grayish tumor. Tumor is resected. And then again, you see here, this is the pseudocapsule of the tumor, and the yellow structure with this typical vascular pattern is the anterior lobe. Tumor is removed. There's no CSF leakage because the diaphragm is relatively thick. When you look inside, you see it's only gland. And then we put some gel foam inside. Some fibrin glue can be used. And then we put this resorbable plate and wedge it against the bony margin. So sometimes we not always use fibrin glue if there is no CSF leakage, but we had it open already on the table. Otherwise, you don't need it. You can just use this resorbable plate, and you see very nicely the post-op MRI looks much better as when you have fat inside, because you can really differentiate. This is a normal gland, and this is defect where the tumor was. It's a Nasal lady, it was 72-year-old lady with an incidental finding, but then it was a growing lesion. And you see it has already close contact to the chiasm. So surgery was performed, and you see the bone here is very thin. It's opened widely to the side. Then the dura is open, tumor is resected. The tumor is going through the wall of the Cavanaugh sinus around the carotid, which was seen. And then here, is a very thin diaphragm. It's a small tumor residual on the diaphragm, but you see it's very thin. And that's why it's always required you reconstruct it. Even if there was no CSF flow, I would reconstruct it. And here I use Duragene, fibrin glue, then again gel foam to fill the dead space. And then again, this resorbable plate is wedged under the bone to have an epidural location. I think it's very important. I had a patient with also very thin diaphragmous celli after resection, and I did not reconstruct much, just gel foam. So I did not reconstruct the bony cellar floor. And then he was sneezing shortly after extubation. Then a fountain of CSF came from the nose. So I think it's good when we have a reconstruction of the bone to prevent this. Fat is used when we have major CSF leakage, or also in this case, it was a 70-year-old female. She became symptomatic with a partial pituitary insufficiency. And you see she has this tumor extending into the right Cavanaugh sinus, going around the carotid. A complete encasement of the carotid on the right side. So it's very, very useful to identify the carotid before it enters into the cellar. In the clival area, you see the carotid is coming here. So I have an identification, then I know where I can open the dura. First, the intracellular tumor part is removed, and then the tumor part from the Cavanaugh sinus is removed. This is a soft tumor. This is the medial wall. The Cavanaugh sinus is opened by the tumor. Then with scissors, we make it wider to get full exposure. If it starts to bleed, you know that the tumor is removed. And you see here, the carotid is completely free. And then it is of utmost importance that this carotid is covered. I think Giorgio Frank was the first who presented a case where he removed a chordoma and he left the carotid open. It was not covering, and it was not covered by dura. And then he had a delayed spontaneous rupture of the carotid after 2 or 3 months. And that's why if you have exposed the carotid and it is not covered by the dura, you have to cover it. And then I think fat is the ideal material to protect the carotid from being rupturing in the future. This was a patient who became symptomatic with certain of palsy, and you see here is a lesion in the posterior clinoid. It looks like a chordoma. You see the posterior clinoid is involved. We could not harvest a nasoseptal flap in this patient. The posterior clinoid is removed after you make sure that it's not making a bony circle around the carotid, as we have heard in the previous presentations. So the posterior clinoid is removed, and you see the big dural defect remains. And this has to be closed. There's some soft tissue behind the carotid is removed. You see the basilar apex here. So it's a big hole. We have no flap. So what can we do? You could take fascia lata in this case, or what we did, we just put one piece of fat in the dural defect, and then we filled the clival area with another fat, put some fibrin glue, Tachosil and gel foam, then tamponates and the lumbar drain. And after 2 days, we had to make a revision because there was CSF leakage, but that could be easily solved with another fat and glue. He refused radiation, and he is without recurrence 8 years after surgery now. There's another patient with a dural, with a clavicle tumor. She had a thyroid cancer in her history, and you see here's a destruction of the bone. It looked like a chordoma, but could also be, of course, another lesion. We make a surgery. Fortunately, it was not a metastasis, but it was a chordoma. But you see it's a big dural defect. It's a lower clavicle area. So we put some inlay fasciolator into the defect, fix it with fibrin glue. And then we put a second layer fasciolator as an onlay and fix it with fibrin glue. Nasoceptive flap was not possible because a biopsy was taken and the pedicle of the flap was destroyed. And then we put some fat, fix it with fibrin glue, more fat, fibrin glue, then one layer of Surgicel or cellulose, fibrin glue, and then the next layer is gel foam. This is simply placed to avoid the tamponates get sticking to the reconstruction, and then tamponates and the lumbar drain. But of course, in these cases, a nasoceptive flap is much better. The nasoceptive flap should always be taken when you expect that there is a dural opening with a major CSF leakage. When the nasal flap is taken, you can tailor it to the expected size of your skull base defect. It's important that you leave here this area because of olfactory mucosa. And then what we do always is that we take from the contralateral side a reverse flap. And this is used to cover the area where you took your nasoceptive flap from. And that is really a big difference in the post-op outcome of the patient. The revitalization is much faster than when you leave the denuded septum completely without any covering. See here, this is the olfactory mucosa. It is in a superior turbinate area and on the medial side of the septum, the upper side of the septum. So that's why the flap should be at least 1 centimeter below the skull base in this area to preserve a good olfaction. And here you see the outline of the incision. This can be very wide. You can also take the floor of the nasal cavity if you want to have a very wide flap. Usually it's enough when you take all this area from the nasal septum and the pedicle is here. Then we remove the bony septum, about half of the septum, and then we flip the contralateral mucosa over this denuded septum, and then we fix it with 2 or 3 stitches here. So the reverse flap has really changed the outcome of the patient, especially in the early post-operative phase. You see the vascular supply of the nasoceptive flap is by the dorsal nasal arteries, which are branches of the sphenopalatine artery. Sometimes you have just 1, but most of the time you have at least 2 or 3. Here's one example. You see this is a defect, what we have in the clivus. This is a dural defect. You see the brainstem here. So we place a little bit of fat inside, fibrin glue, and then over it's a nasoceptive flap. The nasoceptive flap should overlap the bony margin at least 5 millimeters. Better is even more, 8 or 1 centimeter, because the flap is shrinking a little bit. That's why it should at least overlap 5 millimeters, if possible more. And it's very important that you drill all the bony septi at the sphenoid sinus, so you have a plain area where the flap is sitting on. The next thing is you have to remove all of the mucosa to have a good healing of the flap. And what I do not understand, what some people advocate, is that they put some artificial material between the flap and the bone. I think that is completely wrong, because you want to have an early revascularization of the flap from vessels which are in the bone. So that's why don't put anything between the flap and the bone, just the flap, so that you have an early revascularization. And if you make a post-op MRI, usually you see a very good enhancement of the flap. Here's one example. So we take a monopolar electrode to cut along the choana, and then we go at the floor of the nose, coming anteriorly. Then you have to be careful that you do not perforate the cartilage, the septum in front. Otherwise you get trouble with your ENT. And then we stay 1 centimeter below the skull base and make the uppercut. And then we store the nasoseptal flap in the pharynx, or if you want to go to the caudal part, we put it into the maxillary sinus. Here's one example, patient with a huge craniopharyngioma. You see the whole third ventricle is filled with a tumor, and we had a big hole. We see into the third ventricle. It's completely open, and this is a high risk leak, of course. So we put fat, fibrin glue to fix it. You should take care that it's not falling into the cavity, and then the nasoseptal flap. So we have always used fat and flap, and the Napoli group has added the flash, the early mobilization, which also prevents that you get a CSF leakage afterwards. So another patient, this was a meningioma, and here we just put gel foam because the arachnoid was completely intact. So if the third ventricle is not opened, you have not such a high risk of CSF leakage, and then it's okay when you take gel foam and then the flap instead of taking fat. So with the nasoseptal flap, you can decrease the post-op CSF leak under 5%. If you look to the literature, some people even state it's less, but if you are under 5%, I think it's a very good result. Then complications for endonasal surgery, I want to mention two. One is the diaphragma decision. You see, this was a non-secreting adenoma, and it goes far up. So we make a standard approach, and then as I usually cut, I stay under the tuberculum, far under the tuberculum, because I think this is safe. But in this case, you see immediately CSF leakage occurred, because obviously the diaphragma origin is much lower than expected from the pre-op MR image. Then we resect the tumor, and you see a major CSF leakage. So tumor resection is continued. And here you see, this is inside the dura, this is above the diaphragma. So I cut it completely, the diaphragma from the dura. And then to close this, glue, it was, I think, not sufficient. So we stitch a dura with the 0.5 suture, still a little bit rigid, to tie the knots in the depths. But I think it's worth to do it because this was really a big hole. So I thought it might be better when we place some sutures to adapt the dura to the diaphragma. But this was completely unexpected, that obviously the diaphragma position was much lower than expected from the pre-op image. And as Sebastian said in his presentation, it's a little bit time consuming to bring the sutures and to tie it in the depths. But can be done. Then I put some fat in to fill the dead space, and then fibrin glue. And then again, I use this resorbable plate, which gives a good buttress. And then another fat. And this is the post-op result. And this is after 3 months. And now you see after 1 year, the fat is almost completely gone. But it's interesting, when you look here at the image, we think the diaphragma is pushed up and we can cut here, it's no problem. But obviously, there was a folding of the diaphragm because the original position of the diaphragm was that way, and then the tumor pushed it up so that we had the duplication of the dura here, and that's why I cut straight through this. This is unusual, but can happen. And then I want to present my worst complication. This was a 40-year-old female, which was originally a male. So he was on the high dose estrogen. He was HIV positive. And he had a loss of visual acuity on the right eye. And you see a really nice small tuberculum semimeningioma. You see the steep tuberculum. So this is an ideal case to make an endoscopic endonasal resection. So at first we drill the skull base, the tuberculum. We unroof the carotid because the tumor was located in this area. You see the right carotid here. Open the dura. And then you see the tumor has a good arachnoid plane, was easy dissection by manual dissection, not simply pulling. Look around, dissect the arachnoid by manual dissection as we used it in the microsurgical transcranial approaches. Tumor is removed. Then we resect a little bit of the infiltrated dura. You have to be careful because here somewhere is the ophthalmic artery. With the kerosene, I remove more of the dura. And you see this is the view you have. You see the superior hypophyseal arteries, this is a stalk, and this is a chiasm. Everything looks good. And then usually we wanted to take a FET at that time, and then my assistant said, oh, we can try Tachocele. So I placed a little bit of Tachocele, which also is a collagen with these thrombo components, that you have some fixations and fibrin glue, and then the nasoseptal flap. So this was a very easy and nice operation. And after surgery, the patient reported that his vision on the right eye became better. Then, in the night, 12 hours later, he started to complain of visual loss. And we made an MRI. See the nasoseptal flap, looks good, everything looks good. Of course, we make immediate revision because something must be wrong. You see, this is the Tachocele. We remove the Tachocele. And then you see what happened. Both superior hypophyseal arteries are thrombosed, and all the vessels, chiasm, are thrombosed. This was very bad. And you see, this is the visual field, what he has after surgery, just one half of one eye. And you see there is an edema as a sign of ischemia. So obviously the Tachocele led to the thrombosis. I talked to the companies and they said, no, it cannot be because of the Tachocele, because immediately if it becomes wet, this coagulation process goes on. It cannot be that after so long time it is related to that. But I think it must be, maybe the vasculature is more permeable to the factors of this Tachocele, that there is a coagulation initiated. So, but my advice is I would never again in my life put any Tachocele close to any vessels of the optic apparatus. Thank you for your attention.
Thank you so much, Henry, for sharing with us your tips and tricks, your experience, and also your complication. It's always easy to speak about the complications, but very interesting to know what we can do and what we must avoid. And definitely those advice are truly relevant. we have the chance now that Luigi Cavanaugh has the opportunity to join us. It's for me a way to express my thankfulness to all the speakers. I know all the efforts it represents to join us. Mahmoud and Sébastien have to leave us because they have other commitments. Luigi was in the operating theater, but join us. And I would like to thank you, Luigi, to come. I hope you were not too much under pressure during your surgery. So it's a pleasure to listen to you and to know how you do a standard pituitary procedure. Please.
Thank you. Sure. Okay, can you see the screen?
Yes, perfectly.
Okay, thank you. I will just try to give some tips and tricks on standard pituitary surgery, just to show the standard procedure to the cell. This is the evolution we had from the Egyptian to modern time. And originally, the use of the endoscope was described by this French neurosurgeon, Gérard Gouillot. And this is the original view.
The following photocinematographic recordings were taken for the first time during a transsphenoidal hypovisectomy in May 1962. Purposes, cinematographic recordings can be taken during this phase of the operation.
The rostrum.
After the resection of the septum, one can see the rostrum of the sphenoidal sinus, and this reminds one of the prow of a vessel. After the removal of the tumor tissue, the cavity of the tumor is exposed. At the bottom of the cavity, one can observe the diaphragm of the cellar transmitting the pulsations of the...
Okay, so you see how was appearing the supracellular system at that time, but the principle was absolutely right. To bring something from outside, put the endoscope through the cell just to explore the descent of the supracellular system and the cellular cavity. This is what we can do today, but the principle was valid already 50 years ago. You see? So Gérard Gouillot really has to be considered the true pioneer of the endoscopic endonasal technique. But of course, at that time, the overall quality of the endoscope was quite poor, and we had to wait more than 30 years before we start to be able to use again the endoscope through the nose. So this is our trajectory. You saw already in a lot of presentation, but it's very important when for the first time we enter with the endoscope through the nose to find the correct orientation. The common mistake is to enter with the endoscope with an oblique trajectory, and instead of visualizing the choana, which is the main landmark, you will fall inside the ethmoid and risk to enter the anterior cranial fossa. So just to give some landmark, when you enter into the nasal cavity, you have to follow the inferior turbinate, which guide you to the choana. Then the middle turbinate will guide you to the sphenoethmoid recess, and along the sphenoethmoid recess, you can find the sphenoid ostium, which is quite often covered by the superior turbinate. So this is a panoramic view. You see inferior turbinate guide to the choana, middle turbinate to the sphenoethmoid recess. So first reach the choana, then angle up the endoscope along the sphenoethmoid recess, and then enter the sphenoid sinus. Of course, you can even see the cell through the sphenoid sinus, but before try to manipulate the instrument inside the sphenoid sinus, you have to enlarge the anterior sphenoidal wall. Okay, in doing that, you have to respect the vascularization of the posterior nasal cavity coming from the posterior nasal artery and the from the nasoseptal sphenoidal artery and from the posterior nasal artery. Then you enter into the sphenoidal sinus, And again, you have to remove all the septation inside the sphenoidal sinus, not just the septa inside in the midline, because the risk is to fall inside the concameration of the sphenoid sinus, which you can believe that is the full sphenoid sinus cavity, but that could be just a part of the sphenoid sinus. So whenever you enter the sphenoid sinus, it's always good to remove all the septation inside the sphenoid sinus. You know the different type of variation of the sphenoid sinus cavity. This is the panoramic view you need to have when you have to approach a pituitary tumor. So this is your target, but you have also to see the bony prominence of carotid, the planum, the optic prominence. And you have always to open as much as possible the cellar floor, especially when you have to remove small intracellular adenoma, because you absolutely need to move properly the instruments, by manually the instruments inside the cell. This is the gland, you know, it's a sort of a conductor of endocrine gland. And again, you see, you follow the inferior turbinate. This is an anatomic video. You will reach the choana. This is your main landmark for the nasal stage. You see the Eustachian tube. Then along the sphenoethmoid recess, you can reach the sphenoid os, which is not absolutely an important landmark. What you have to recognize is the roof of the choana, because just above the roof of the choana, you will find the floor of a sphenoid sinus cavity. Then you detach the nasal septum from the sphenoidal pro. In this way, you increase also the maneuverability of the instrument, complete your anterior sphenoidotomy, and then you expose the cell. So basic concept, never do middle turbinectomy for pituitary surgery. Of course, there are some acromegalic patients in which you have a very large hypertrophic turbinate, and you are some way obliged to remove one turbinate. But otherwise, in the vast majority of the case, there's no need to remove the middle turbinate. You just have to lateralize. Do wide sphenoidotomy in the use to nostril. Three main steps. During surgery, what we do at the beginning is to use this cotonoid soaked with diluted adrenaline and local anesthetic, just to make decongestion and protect the turbinate when we lateralize. So this is what we do. We lateralize the turbinate. We coagulate with monopolar the sphenoethmoid recess. We detach the nasal septum from the sphenoid pro. We resect a limited portion of the posterior nasal septum, complete anterior sphenoidotomy. And when we do that, we have to be careful of any bleeding of the sphenopalatine artery. And in case we have to coagulate with bipolar forceps, this vessel. Monopolar is not enough. It's not good to coagulate branches of sphenopalatine artery. Then we have to expose all the landmark on the posterior wall. After that, you have to open the cellar floor as we do with the microsurgical transsphenoidal approach. In doing that, we have to remember the extreme variability of carotid artery prominence around the cella. And this tortuosity of a carotid artery is particularly evident, especially in acromegalic patients. You can have sometimes kissing carotid just in the middle of the cella. So always to check the position of a carotid artery, not only at the level of the cella, but also along the floor of the sphenoid sinus, because it's not so rare to have a prominence of the petrous portion of a carotid artery inside the sphenoid sinus. For this reason, it's very good and useful to use the microdoppler probe, and then you have to remove the pituitary tumor. As a general rule, we always start from the bottom of the cella, then we decompress and remove the part of the tumor growing toward the cavernous sinus, and only at the end we remove the upper part of the tumor. This because if you early enter and remove this part, you will have the descent of the supracellular system, which will obliterate the cellular cavity and will condition the removal of the tumor inside the cavernous sinus. Not so frequently it happens, but if you have a good plane and you have a not soft tumor, you have sometimes the chance to do this sort of pseudocapsule resection. You can use the compressed gland as a plane to remove the pituitary tumor en bloc. This is very effective, especially if you have a functioning pituitary tumor like this acromegalic one, and you see here the normal pituitary gland. There are so many ways to remove pituitary tumor with the endoscope. This paper we made 20 years ago. We propose hemisphenedotomy, unilateral approach, but honestly, what we do today is always a bilateral approach because you need the converging action of the instrument. You need to have a proper maneuverability of the instrument. Even if you have a small pituitary adenoma, it's always good to expose widely the entire cell and not just to preserve part of the sphenoid sinus, which is absolutely not necessary. Just a few words beside pituitary on cystic cellular lesion because they seem to be quite easy to remove, but it's not always the case. Look, for example, this large cystic lesion. You see, this was a rat kidney. That was a mucoid suppression. And when you have a lesion like this, you have just to empty. You have a prolapse of the cistern. You can navigate with the endoscope all around, but the procedure is ended. Just empty, and that's all. With good control, you don't need to do any particular reconstruction. But different is the situation when you have a case like this one. This seems to be very easy. This is a common arachnoid intrasupracellular arachnoid cyst. But you see, when you explore this cavity after opening of the dura, you see that the CSF doesn't stop to come. And this because the cyst is communicating with the subarachnoidal space. So when you have a situation like this one, you have absolutely to close properly this cavity because the risk of a CSF leak is quite high. So when you have a cystic lesion inside the cell, it's always good to avoid very large bone and dural opening. First, do an exploration of the cavity with the endoscope, and if there is a communication with the subarachnoidal space, fill completely the cavity because the risk of a CSF leak of this patient is quite high. Look, for example, this other arachnoid cyst seems to be quite easy. We open, you see the CSF coming out, the cistern prolapsed down. Apparently, there was not a communication with the subarachnoid space. We made Valsalva maneuver. No CSF was coming out, so we just pull some pat some fibrin glue. We close even quite hardly the floor of the cellular cavity with the dural substance and also with the mucoperichondrium. But you know what happened? This patient had leakage, post-op CSF leak. And in fact, this was a communicating arachnoid cyst. This time, we fill the cavity completely with the fat, and then again with the dural substitute, we cover with the mucoperichondrium and pack the sphenoid sinus cavity with fibrin glue. And you see the post-op with the control with the piece of fat. So very important to use fat, which is the main material we are using. We have almost abandoned also this dural substitute. Fat and mucosal flap are enough to close the skull base defect through the nose. But anyway, if you want to put some dural substitute, is better to encase in the epidural space. not inside the cell. And always remember, as Henry Schroeder say, fill the empty cavity. Natura abhor a vacuum. Nature hates dead space. So this does not concern only the cellular cavity, but also in other districts. Whenever you have a huge empty cavity, it's always good to fill with some material. And I think that's all from my side.
Thank you so much, Luigi. Is there any question from you?
I think everybody's tired.
Yes, it's already late.
Yeah.
You made the conclusion, Luigi. It was very nice. The question from you? I see from the audience a question maybe for Luigi or Henry, or to decide whether to do a complete hypophysectomy or partial, or which part to remove. It's a question from a colleague from India.
For whom?
I think it's maybe in Cushing's disease.
In Cushing's disease, we remove the adenoma if we see it. If we do not find an adenoma, then we make an exploration of the gland with vertical incisions. And then if you don't see anything there, then you should rely on the Petrus sampling. If there is an indication that on the left side or right side should be the problem, then you can make hypophysectomy as a half. I would never take the whole pituitary gland out, but just take half of it. If there is a sign, is it left or right?
We just had the discussion with Luigi a few hours ago.
Some people say you can take both sides, but you should leave the middle part with a stalk. So leave a little bit. There is some anterior gland attached to the stalk, and of course you shouldn't leave the neurohypophysis as well. So the posterior lobe should be stay. Luigi, correct?
Yeah, but somebody proposed this, but from an anatomical point of view, I don't like, because the cell which produces CTH are in the midline. So there's no sense if you don't find the tumor to resect the lateral part. Because
but how do you know? It can also be in a lateral part.
No, I mean, from an anatomical point of view, the cell which produce a CTH are in the midline. So why to go laterally? As you say, I follow the gradient of a CTH on petrosal sinus sampling, but I don't do explore laterally just because I didn't find the tumor. Maybe I was not so clear, but the principle is to not resect the gland without any gradient on petrosal sinus sampling.
Yeah, sure. Then there was a question, do you prefer the use of fibrin glue at the end or in between, like sandwiches? So I don't put any fibrin glue between the bone and the flap. I put some fibrin glue between the dural edges and the fat, but I take care that no fibrin glue goes on the bone where the flap is placed. So the flap should be exactly in contact with the bone, and then I put the fibrin glue around. I think it's very bad. Some people even put some Duragene in between the flap and the bone. I think this makes no sense at all.
Yeah, absolutely.
I see the last question.
Dead material. Fibrin glue is dead material. It's just to support the other material, but does not favor the healing. I completely agree, Henry.
Yeah.
I see the last question. How long do you keep the lumbar drain? It's for Henry, but I think, Luigi, you are never putting a lumbar drain. Henry, you are putting one for how long?
For 5 days, usually. So especially in the chordomas. For example, you have seen in the lady where we had no flap, and there was a chordoma, there's a high risk of CSF leakage. And there we put a lumbar drain to decrease the pressure.
So I will ask to Luigi, in which indication do you maybe place a lumbar drain?
No, usually no. Usually no. Even in tumor growing inside the third ventricle or chordoma, we are trying not to use anymore.
And if there is a post-operative CSF leakage, then you place a lumbar drain or not at all?
No. What we do if there is just a small CSF leak, we try to fill the sphenoid sinus with fibrin glue injection. We go with the mobile cart, endoscopic mobile cart to the ward, and we inject some fibrin glue inside the sphenoid sinus. If we have just a small CSF leak, otherwise we prefer to reoperate and put some additional fat in the cavity. But we used it a lot in the past, lumbar drainage. But at the end, we had leakage even with lumbar drainage. You remove the drainage after 5 days, and after 7, 8, 9 days, the patient can start to leak. So for us, it's very important to mobilize the patient as soon as possible. Usually 1-2 days after surgery, and leave them. Let them to start to work, and for us this is more important. Of course, there are situations we have not to be dogmatic. For example, patient already irradiated, the patient in which you have already made the surgery and you don't have a wide nasoseptal flap or material for the reconstruction, so it's okay. You can need it, but for primary surgery, we try to avoid its use.
Yeah, I think also if you have a good nasoseptal flap which is covering everything and you have a good reconstruction, then I think the lumbar drain should not be used. But if it is a posterior fossa, you have no nasoseptal flap, I would always place a drain, because it can be a disaster. I know one surgeon who had done at least 15 revisions in a chordoma case which was leaking and leaking and leaking. And we had one early case of a craniopharyngioma. He presented with hydrocephalus. And we put a lumbar drain, and it was good. We removed the drain, and as Luigi said, it starts to leak. Then we put a ventricular drain. It was fine. Then we removed, and he starts to leak again. And then finally, he ended up with a shunt. We placed a shunt, which was removed after 1 year. So there was, although there was a nasoseptal flap and it was covering everything, I think he had a high pressure and high intracranial pressure. That was the reason. I don't know.
Yeah, you're right. I think so. Some patients have an increased intracranial pressure, even without being symptomatic for that. But they are horrible. They produce more CSF than other patients, and whatever you do, it's quite impossible to close that. Yeah. Regardless the type of lesion you have removed. Some patients are really horrible.
Yes.
Yeah.
In your protocol, Luigi, you mobilize very quickly the patient after the surgery, but you have also recommendation during the night, and it's also important to comment on that. I will let you comment.
Yes, to leave in semi-sitting position, never leave supine the patient, because where you have the hole, there are no auto-regulation mechanism of the intracranial pressure. So if you leave the patient supine, the pressure on the skull base will be higher. If you elevate the head of the patient, the pressure at that level will be reduced. You can try to do this even during surgery, when you do an extended approach and you put fat inside the defect. If you elevate the head of the patient, you will see the fat that will be moved more intracranially than outside. If you put the head of the patient down, you will see the fat that will be pushed out. This is a simple way to demonstrate why you never have to leave the patient supine in the bed after this kind of approach.
Yeah, I completely agree. At least 30 degrees up.
I have one more question.
Stefan, please.
Just in regards to closure in, for example, clavicodoma in redo cases or delayed flap failure after proton therapy, whatever. What's your strategy? Would you use a free flap, or would you do some more complex temporoparietal options or artificial materials? What do you use?
If it is radiated, you mean? If it is radiated?
Yeah, and just if there's no flap available, just for a redo operation or for a delayed failure after radiation or infection or whatever, and you need to close, would you do a free flap, a fascia lata flap, or artificial material, or a temporoparietal via the ATF?
Temporopolar flap.
Yeah.
Must be
In
vessel.
a current post-irradiated, you need a vascular pedicle flap.
Exactly.
So
No
that's
way. No way.
Okay.
Or
It's
you
not
talk to
aggressive
your,
approach.
yeah, we have craniofacial surgeons, they are very familiar with vascularized flaps. They can make a vascularized flap, but you need something which is living. If you put that material in an irradiated area, it will not work.
After 70 gray, after prototherapy, there is no vital tissue to try to fix. It's a need a new vascular pedicle flap.
Yeah.
Only way.
Yes. There's one more question here. Do you use Duragene by closing such a defect of the dura? So we use Duragene only if it's a small defect, mainly to augment the diaphragma. So what I showed, it was a pituitary tumor and the diaphragma was very thin. It was just only a layer of arachnoids, and I used Duragene to augment it because I had this case which sneezed after the extubation and then a fountain of CSF came from the nose. That's why I reconstruct, I augment the dura and then I reconstruct the bony floor with this resorbable plate.
So we are gently arriving, I think, to the end of the webinar. It was very interesting and attractive. Thank you to all of you, as usual. It's an opportunity to invite all of you to the next ENS skill-based section webinar, which we take place mid-December, 15 December. And now we will move and in the next webinar, maybe more discuss other approaches. And the topic on mid-December will focus on the pteonal approach. So you will see different angle of vision to reach many pathologies. And I hope to start with an anatomical overview with Stefan and then move us with the same format than today. Very interesting to have from the basic to the clinical applications, the how I do it technique and the other ones. So thank you to all of you. It will be a great pleasure to meet you next time, and we keep in touch in the meantime or whatever.
Yeah, have a nice evening. Thank you.
Bye-bye.
Have a nice evening to all of you.
Everybody. See you.
Bye-bye.